What you're about to hear next represents a new approach. A city, specifically this city, New York City, recognizing that healthcare affordability is a public health issue. New York City established the Office of Healthcare Accountability through Local Law 78 in June 2023. This is the first office of its kind in the country, with the city taking the lead by examining hospital pricing, market concentration, and healthcare business practices in the New York City area. Earlier this year, the office released its inaugural Healthcare Accountability Report, which analyzes hospital prices across New York City systems. To discuss these findings, we have three leaders: Emma Clippinger, Claire Levitt, and Suzanne Taranto. Emma Clippinger is the acting director of the Office of Healthcare Accountability, located within the Department of Health and Hygiene. Emma has helped lead the development of this office and the creation of the inaugural report. Claire Levitt serves as Deputy Commissioner at the Mayor's Office of Labor Relations, where she oversees health strategy for the city employees and retiree health plan. And Suzanne Taranto is a principal and consulting actuary at Milliman and a member of the American Academy of Actuaries, and was a key source of analytics for the city health plan. Please join me in welcoming Emma, Claire, and Suzanne.
Good afternoon. Thank you so much to 32BJ for having us here today. My name is Emma Clippinger, and it is my great honor to serve as the first Director of Healthcare Accountability within the city's Department of Health. I'm going to kick things off today and tell you a bit about the Department of Health's commitment to healthcare accountability and the top-line findings, which you've already heard a bit about from our inaugural report. I'll then pass it over to Claire Levitt from the city's Office of Labor Relations and Sue Taranto from Milliman, who will do a deep dive into some of the pricing data contained in the report. All right. As you have also heard, in 2023, City Council unanimously passed the landmark Healthcare Accountability and Consumer Protection Act, known to those of us in government as Local Law 78 of 2023, which created the nation's first local office of healthcare accountability. Councilmember Julie Menon not only architected and introduced the bill, but she has also been a tireless advocate for ensuring staffing and funding for the office. And I know she is no longer here, but I grabbed her and just want to say to everyone just how deeply grateful we are for her support. The law imbues the Office of Healthcare Accountability with a number of critical responsibilities, including analyzing healthcare expenditures for city employees, publishing an annual report on enumerated topics, convening key stakeholders across healthcare to discuss the findings of that report, maintaining a website with a price shopping tool, and providing policy recommendations on healthcare affordability and related topics. So today, we're going to focus on the first two highlighted here on the slide, but as you can see, we have a lot of exciting work underway, and we look forward to an ongoing public conversation with key healthcare actors, including many of you in this room, as well as healthcare consumers, also known as patients, about the harmful effects of high and rising costs of care and what we as a city can do about it. Which perhaps brings me to my next point, which is that the city does not have regulatory authority over healthcare. That largely rests with the federal and state government. But, and let me be clear, that does not mean that we must forfeit the opportunity to be active participants in shaping our city's healthcare systems and ensuring that they meet the needs of all New Yorkers. Moreover, the city puts significant public dollars into both public and private nonprofit hospitals through budget appropriations, discretionary grants, property tax exemptions, and healthcare coverage for city employees. Indeed, as you will hear from Claire, the city itself is the largest purchaser of healthcare within the city and is among the largest in the state. I stress that we are the first local office of its kind because there are a number of well-established precedents at the state level. And when we looked at the state offices, much of what we see that they are doing is critically examining the data, producing high-quality analyses and reports, defining health needs, and making evidence-based policy recommendations. And that is precisely what we do at the Department of Health. Public health folks in the audience may be familiar with the commercial determinants of health framework, which acknowledges that there are potential benefits and threats to public health of all commercial activity. So when we set about evaluating the business practices and behaviors of healthcare as a public health issue, we ask questions such as, is there a strong association with healthcare access, with physical and mental health outcomes, life expectancy? Do patterns occur at a population level? Are patterns inequitably distributed by race, ethnicity, wealth, neighborhood, and other key demographic factors? Ultimately, from our public health lens, we found overwhelming evidence that the business practices and behaviors of the healthcare industry have a direct impact on community and population health. At the systems level, adverse outcomes include segregated healthcare systems, overcrowded and underfunded safety net institutions, safety net closures, race and insurance-based discrimination, underinsurance, denials of medically necessary care, medical debt, and increased morbidity and mortality. At the individual level, adverse outcomes include lost wages, delayed or foregone care, rationing prescription drugs, trade-offs with food and housing, debt, stress, and worsening health. Furthermore, these adverse health-related outcomes are inequitably distributed by race and income. From our perspective, healthcare accountability is not strictly about monitoring whether key healthcare actors, namely providers and payers, are in compliance with state and federal regulations. Our ultimate goal is accessible, affordable, equitable, and high-quality healthcare for all New Yorkers. So today, we are focusing on the analysis of the city's comprehensive benefits program and key findings there, but I do want to provide a quick snapshot of what else you can find in the annual report, which was released in March of this year. As per the local law, our annual report focuses largely on publicly available data sources. Of course, we all know that just because data is publicly available, it does not necessarily mean that it is accessible or intelligible to the public. So a lot of what we do is aggregate, clean, and analyze this data for the city level. The inaugural report provides a good template for what we can expect on in the future, as we will be updating and releasing the report on an annual basis. Though I expect that this will also evolve over time as our understanding of this data deepens and new data comes online. So we have our analysis here of the city claims data, that's number one, which was done by Milliman, and you're gonna hear more about that shortly. We also have an analysis of price transparency data for the city. This is the pricing data that hospitals and payers self-report under the new-ish CMS regs. Turquoise did that analysis for the city. On the hospital side, we largely looked at IRS 990 data and CMS cost report data to look at spending and community benefit spending in particular. We have some interesting analyses of community benefit spending versus payer mix for inpatient discharges. This is a very rich issue and area for policy debate about how to best design, measure, incentivize, and enforce community benefit, and it is something that we are watching closely. The publicly available data on the payer side, I will say, is a bit spottier. We look at public filings, both at the federal and state level, and also thanks to a law that was recently passed at the state level. For about the past 3 years, our Department of Financial Services has been collecting and posting self-reported data from insurers on claims received, claims paid, and claims denied. Needless to say, the healthcare system, as we all know and have talked about today, is vast and infinitely complex, as is its data. There are some things that are not up here that I'd say we are already looking into and figuring out how to best report, such as pharmaceutical pricing. I will note that we face a couple of significant limitations. One is getting city-level data. Not all data sources are reported at the city level. And the other is a lack of publicly available all-payer database. When we look at what state-level offices are doing, most of them are working with data from their state's APCD, and we are hopeful that the New York all-payer database will come online soon, as we believe it will greatly strengthen our work. There is a lot buried in this 250-plus page report. But the headline is that New York City faces a healthcare affordability crisis. This is not a new phenomenon, nor is it unique to New York City. However, the affordability crisis has grown increasingly acute as the costs of healthcare continue to outpace wages, inflation, and economic growth. Top-line findings from the report include high and rising commercial prices, highly variable commercial prices, which we will dive into in a bit, high and rising healthcare premiums, an average community benefits spending for city hospitals of about 18%, and high rates of commercial claims denials. I do want to say, before I pass the mic over, that ultimately the harmful effects of high and rising healthcare costs are overwhelmingly borne by people. Right now, we are on day 9 of the federal government shutdown, and one of the central sticking points, as we know, one that clearly and directly hurts people in states red and blue, is healthcare affordability. I would be remiss if I did not acknowledge, as others have so thoughtfully today, that the healthcare access and affordability landscape has shifted dramatically since our report was issued, and it is going to get a whole lot worse. I don't have to spell out the short and long-term impacts for this group, but I will say that we are very focused on how we can translate these systems-level analyses for people. How do we meaningfully help working-class New Yorkers get the care they need, including preventive care, and navigate an increasingly unaffordable and inaccessible healthcare system? I look forward to working with all of you in this room in meeting these challenges and this moment. And I'm going to pass it over to Claire, who's going to talk to you about this work as it relates to a very sizable city population, city workers.
Thanks, Emma. Thanks, Emma. Before I go into the details about the city reporting, I want to share a couple of anecdotes about how my interest got piqued in hospital pricing about 15 years ago, before I actually came to the city. As a fund administrator, we negotiated high-cost hospital claims, and I learned some of the ways that insurer contracts and hospitals didn't really work for employers and funds. 2 claims stuck in my mind all these years in particular. One was a hospital claim where the insurer had permitted the hospital to exclude certain items from the DRG. So we ended up with, in those days, what was a large bill, a $50,000 procedure, an orthopedic procedure, and an add-on of another $50,000 for screws. The screws, of course, probably cost like 9 cents a piece, but it actually doubled the hospital bill. We also had another hospital bill where the hospital charged a full $600,000 DRG for a patient that arrived in the emergency room DOA. The patient was kept on ECMO for 2 days in order to harvest the organs for transplant, but they still billed the client for the full $600,000 DRG for a dead patient. So those were some of my introduction to the world of how hospitals maximize their revenues. So fast forward, and I've been now 11 years with the City of New York. And this has been one of my interests in working for the city, and hoping that the city could really leverage its large size in working with hospitals. So New York City, I actually said one of the largest purchases of healthcare in the city and state. Emma said it was the largest. I didn't want to get into a fight with the state about who was larger, because we've had those discussions over the years. But our total employee spending consumes over 10% of the city budget. In fiscal '24, the city spent over $9 billion just on the healthcare premiums for its 1.2 million employees and dependents and retirees. Plus, we have a specialty drug program, we make welfare fund contributions, and we have a Medicare retiree program that when you add it all up, we've actually spent over $11 billion in fiscal '24, more in fiscal '25. And over $3.3 billion of that was spent on hospital-based care. Our premium expenditure pretty much doubled between 2015 and 2025. This chart shows you 14 through 24. I've included it this way because this is what's actually in the report, because the report was based on fiscal '24 data. But you can see that this has climbed up to where it's almost doubled our costs from just 14 till 24. And from 15 to 25, it actually did double and go over $10 billion. So Julie Menon gave you some of the highlights of the report, but I think it's worth repeating. And I encourage you all to go to the site and read at least the executive summary. It's a very long report, but you can get the gist of it from the executive summary. The original March 2025 report has the analysis by Milliman for the city's largest PPO plan, which covers about 75% of the city's population, about 750,000 active and pre-Medicare retirees. An additional 20% have HMO coverage, for which similar data is going to be provided in the next version of the report. Now, we had been aware of the wide variation in pricing between hospitals for a long time, but the initial report demonstrated to us just how wide it was. Even though we didn't have the Medicare benchmarking in the first report, we compared the hospital pricing to an average of all of the city's hospital costs. And a lot of it validates the things that you've seen on the walls here, put up by 32BJ. What we saw were that some facilities charged as much as 2 times the average cost, and some procedure charges were 3 times the average cost. We also saw one of the interesting outcomes of this was an unintended consequence of transparency, which is that a lot of the lower cost hospitals figured out that they should charge more and demanded increases from insurers in their next negotiations. So there was an interesting unintended consequence to sharing all of this data. Not that it should stop us from doing this and moving forward. So we now have the updated September 2025 city claims report, and this report does include the Medicare benchmarking. The March 2025 version didn't have the Medicare benchmarking. Councilmember Menon talked about some of the holdup in getting that data from the insurers, but this new version of the report that you can see online does have that information. And as Emma said, Milliman, the city's consultant, provided the data analysis for all of the reporting. So what we found is that overall, the city's spending is at an average of 256% of Medicare, with 234% being for inpatient care and 278% of Medicare for outpatient care. Again, what we see is that the variation between facilities and between services, even in the same facility, is really extreme. As Councilmember Menon mentioned, one of the hospitals charges over 900% of Medicare for emergency room charges, while other charges at some of the major facilities are as low as 150%. So I should point out, though, that the hospital that's charging over 900% of Medicare for emergency room has an overall spend of about 268% of Medicare, not much higher than the average amount, but their inpatient is low at 230%, but outpatient is high at 313%. So with Medicare benchmarking, we're able to understand how each hospital system maximizes its revenue. It's like a big balloon. You squeeze it here and it comes out there. They all find ways, whether it's charging more for inpatient, for outpatient, or for emergency room, they've all found ways to maximize their pricing. So I'm going to turn it over to Suzanne Taranto, who is the city's consultant from Milliman. And her team analyzed the millions of lines of data with the city health claims into a really meaningful report. And she's going to give you a deep dive into that report.
Thank you very much, Claire. One of the things that I wanted to start out with before we take some really interesting snippets out of the data analysis is why it's important that the new report used Medicare allowed, or what the value is out of the new report. One of the things in the early report allowed us to compare how much each hospital charged, not only for certain services, but in general. But when we compare overall the case mix of the hospitals, the methodology that we're using is to reprice all of the city's claims using Medicare allowed. So an apples to apples reference that allows us to tie what Medicare would have paid for a very specific service and accumulate that up so that we can compare inpatient and outpatient utilization at the hospitals. So this methodology, which essentially makes very specific adjustments for the services that are being rendered at each facility, as well as individual services, gives us a basis to compare, which then allows us to draw conclusions around the pricing between the different facilities under the city's contract. Let's pick some data insights and take a deeper dive. When we looked at the city's experience over the past 3 fiscal years, we saw that on average, the CBP plan was paying between 2 and 3 times Medicare allowed prices, and that these prices increased over the past 3 years. We separated here on this chart between inpatient and outpatient facility, as well as facility as subtotal, both as a percent of Medicare, the top half of the chart, and on a trend basis in the lower half. And the key observations that we had were outpatient costs are both higher than inpatient costs as a percent of Medicare allowed, and increasing at a greater pace. The pressure from managed care to move services to the proper site resulted in the negotiated price increases that went along to make up for, or to make additional revenue neutral decisions. Breaking that information down further, we looked at the city's top 10 systems and compared the allowed cost that the city was paying as a percent of Medicare allowed, both on an inpatient, an outpatient, and a total basis. We also provided you, for context, the total allowed dollars of spend at each of these facilities. The top 3 systems utilized by city members made up over 50% of the spend, so very influential in looking at the total cost of care from a city perspective. You can see the names of facilities down the side, and you can see, I would note that The average facility allowed is 256%, but as Claire mentioned earlier, we have a range from 184% on average, 184% of Medicare, to a max of 330. And the number varies between inpatient and outpatient, as well as among the different facilities. Let's just look at that for a sec. It's very interesting. Here's a visual that presents the same information, and I think it really highlights some of the key observations of the report. The allowed as a percent of Medicare allowed varies greatly among the top systems. That black bar across is the average total facility charge at 256% of Medicare allowed, but you can see that facility by facility, the bars are very different. In some instances, the inpatient is the higher amount as a percent of Medicare. In others, the outpatient. And you can see that the variation between the systems as you compare it to the average is pretty significant. And this was very important in understanding where the cost for cities' facility charges comes from. Let's do a specific service look. So we looked at emergency room utilization in the city of New York, and I believe that Councilwoman Menon cited this as well. On average, 588% of Medicare allowed, with a range of 945 at the top end to around 412% of Medicare at the bottom end. So you can see that looking at the use of emergency departments and as a potential revenue source or as a source of additional cost is something that was a bit of a surprise to all of us in looking at the data and the report. Here's just a single CPT code. This is the code that's associated with an emergency room visit of moderate severity. And across the bottom, you can see the names of the various hospitals. The average allowed, 2571, but the range of numbers well above that to slightly below that, depending on the facility. I'd also like to point out that the order of the facilities from largest to small, so the names of the facilities ordered from largest to small, is different in this particular example than it might have been in terms of overall utilization or utilization inpatient, outpatient. And you'll see this as we look at another example of a particular code, a single code in terms of average allowed cost. Picking another service, broad service, colonoscopy and biopsy charges, $28.13 per service. Again, the CPT code specific to that service alone, so apples to apples across the board. And again, you can see, based on the bars, the wide range of pricing that we see between various hospitals utilized by the city folks. And we're showing hospitals that had a minimum number of services to make sure that this, we had a statistically credible analysis here. Claire, next steps.
Thanks, Suzanne. So, next steps. The New York City Office of Healthcare Accountability is going to issue a Local Law 78 report annually. The report will include the city health plan analysis annually, and the next version will also include information on the HIP HMO, which covers another 20%. The city also has recently negotiated a brand new health plan that's starting up in 2026. So by sometime in 2027, we should have similar data for our new health plan and be able to make a comparison of what that looks like by mid-calendar year 2027. So thank you all for your attention. I really urge everybody to go look at at least the executive summary of the report. It's got some fascinating data. that'll really help you dive into exactly what's going on at the different hospitals. And we will take some questions now from Keenan.
All right, great. Thanks so much. It's worth zooming out just for a second. 6 years ago, there wasn't a lot of the data to do these analyses. 3 years ago, people talked about how much it was just a total mess. And so for now to have some of this information available, it is really, really great. And it's great to see you translating a lot of this into actionable insights, to use some LinkedIn language. So thank you very much. Again, a lot of these slides are going to be made available after this meeting so that you can also dig into some of these findings, and these reports are also online. Thanks for some folks who were able to submit questions before the meeting. We did have a couple for our colleagues here. Emma, a lot of these are probably going to be for you, but feel free to help facilitate. One is just, what are some of the actions that you're hoping to see as a result of this report?
Thank you. Oh, there we go. Great question. So I come to government from advocacy to government, from advocacy. And you know, one of the greatest advocacy tools in your toolkit is independent, authoritative, high quality data and analysis. All the better if it is from a government source. So I don't mean to dodge the question, but I do hope that this data finds itself into the hands of folks who have those very clearly articulated policy asks, who are looking to slot in that report, that study, that analysis that is going to really help them convince folks, policymakers, the general public, do coalition building, do power building, to see these big systems level changes. And that data is not helpful just in crafting the policy proposal, but you know, also in the solutioning on that side as well. So I am hoping that of the many areas articulated in the report, outlined in the report, that it finds advocates in each one of those areas who will go forth and use this data to enact change. I don't know if folks have anything to add there.
I guess in terms of actionable items from this, I know that one of the things we focused on for our new health plan is looking more closely at chronic disease management programs and hoping to keep people out of the emergency rooms. And now that we've discovered that one of the key drivers of healthcare costs has been the emergency room admissions, we really want to work at keeping people out of the emergency room whenever possible.
Great. Another question that we had was, and Emma, you talked about this a little bit in your slides, but what is that interplay between the city and the state? What would you like to see the state do as a result of some of this work?
I hate to focus so much on data, it's so wonky. But we are a public health department. You know, it is part of our theory of change. We work closely with the state. We have many close colleagues at the state. And I think, you know, more access to data, better data, more publicly available data on these key topics. An interesting thing too is, you know, something like the CMS price transparency data, that was, as I like to say, a kind of dormant authority within the ACA that was finally realized and actualized through rulemaking. And that authority lies at the federal level and at the state level, and sometimes it takes legislation, some rulemaking, but to compel those various actors to produce data, to make high quality data enforcement there, oversight there. So you know, I think it's an ongoing conversation around what city level data looks like and how we can get access to it in terms of identifying city level health needs and health outcomes. But it is a close and good relationship. And when actually the report was a great conversation starter, I will say, I had the chance to speak with the State Commissioner of Health about it. It was really well received. I think there is a sense too, in government, we are sometimes under-resourced. I don't know if you know that. And so I think, you know, having an understanding about who can do which piece of the heavy lifting. It is a really collaborative environment, both across city agencies and the city and state as well.
Great. In this room, we have hundreds of people that have been engaging in healthcare affordability and hospital prices. What are your plans for stakeholder engagement, for convenings that could continue to bring awareness and action on some of these issues?
Yeah, absolutely. You know, I would argue that everyone, if you are living in the United States in 2025, whether you like it or not, is engaged in healthcare affordability. And that has been one of the central challenges of this work, is translating it, as I've alluded to a little bit. The folks in here, you're insiders, you're wonks, you know healthcare, you know the folks who are knew that this report was coming have found us already. Again, it has been such a great conversation starter. But then, you know, it does touch everyone's lives. So I think the work that we're doing right now is a lot of delineating between different stakeholder groups, the insiders, the folks, you know, who know that they are actively engaged in this work, and folks whose lives are so meaningfully shaped, often detrimentally, by this challenge, and reaching out to them and doing some education and engagement, and basic healthcare literacy engagement as well. So right now, I'd say it's more segmented in terms of our engagement, but we do hope to identify the unifying themes and needs to be able to bridge across those discrete stakeholder groups and have more public forums where we can do something like release the report and have its insights be very clear for how it can translate into changes for individuals at the individual level, but also city-state level as well.
I'd say that the Fair Pricing Act is a good starting point for engagement for people concerned about healthcare affordability.
Great. And we have the 32BJ Health Fund Analytics table, which has some handouts regarding the Fair Pricing Act, too, if you'd like to learn more. On the slides, one thing that certainly popped out to me was the slide that had some of the data about emergency department percents of Medicare, where we saw really wide price variations. I think for NYU Langone, it had 945% for outpatient emergency department. Suzanne, maybe this is a good question for you. What does that say? What explains those really dramatic differences within the same market? You work in other markets too, you do a lot of this analysis. What helps explain that, and what does it tell us about how hospital pricing works?
I think my biggest takeaway about hospital prices is that each hospital has a different contracting strategy to make their nut. Essentially, you know, we saw a really wide range of variation in the ER, and maybe the ER is an interesting side because that may be the place where you're getting your most paying patients. You know, there's not an ability from an employer perspective under the Consolidated No Surprises Act to really negotiate much on the emergency room side, so it's sort of a guaranteed payment. But I think it sort of highlights the strategy of determining in contracting with various insurers exactly where you want to make your money as a particular facility. And it varies, and there was no consistency all the way through that someone was the highest in every possible category. It's a little bit of Claire's discussion about the balloon, and so I think it was just a little bit of insight in terms of either deliberate or evolutionary contract strategy and contracting with carriers.
Great. And then maybe just a final question. Again, maybe this, Emma, you can start here, but what do you plan to look into next? You've come out with kind of these two reports. What are the unanswered questions that you hope to dig into next?
There's so much. Where to begin? And drive everyone at my staff crazy with my ongoing laundry list. You know, as Claire was saying, this has come up is the flip side to a lot of what we're talking about is preventive care, is primary care. You know, that's how you save on costly treatments and emergency care. But we know that primary care is woefully underfunded. We face a severe workforce shortage in the state and the city. So it's something I want to really dive into, and I think we all hear anecdotally that no one can find a primary care provider, no one can get an appointment with a primary care provider. So it's something I want to provide a little bit more shape to, and really, as we do study that, look into it, give it some definition. Care is moving outpatient, as we heard as well, and things, there's the hospital-based outpatient ambulatory surgery centers, but then there's the freestanding, non-hospital-based outpatient ambulatory surgery centers. And that's very interesting to me because all of our hospitals in the state are nonprofits under state law. So we do get some insights into data. They do report things. And as things move into more of these for-profit private centers, we don't have access to the same level of data and oversight. So that's something that's interesting to me. You see it in the proliferation of urgent care, for example. Pharmaceutical pricing, a big one. There's so much. There's so much. And again, hope to have what we look at also informed by what we hear back from folks in that stakeholder engagement.
Well, thank you so much. We'll stay tuned for primary care, pharmaceutical deep dives, and further presentations from you all. Thank you so much for your time today. Please join me in thanking them.